of PESTOLA to give me this opportunity to discuss this very interesting syndrome. Because the basis of Noonan syndrome is genetics, the genetic mutations, does any specific gene or any mutation in that gene predict their height outcomes? Because as endocrinologists, we mostly look at their height, and we want to know more about how genetics change that. So overall learning objectives is to look at the various genetic mutations which affect Noonan syndrome, short stature in general, and also look at the role of the most common mutation, the PTPN11 and others. Growth hormone response in Noonan syndrome, again, looking at the PTPN11 and the comparing with the other mutations. Long-term data with growth hormone therapy, and also the malignancy risk in Noonan syndrome and how that plays with growth hormone therapy. So the first known description of Noonan syndrome was actually in 1883 in Latvia. Later on, it was described by Dr. Noonan, who was a pediatric cardiologist, and she described a cohort of short stature and pulmonic valve stenosis, which carried her name after that. The estimated incidence is about 1 in 1,000 to 1 in 2,500. Male, female is about the same. It is initially was thought to be autosomal dominant, but it's only in 1/3 that is autosomal dominant. Majority of the children are born after having a de novo mutation. There is a familial occurrence also reported, and in less than 1%, there is an autosomal recessive form of Noonan syndrome as well. So the diagnosis of Noonan syndrome is primarily a clinical diagnosis because genetic mutations are known in about 75%. So still, even to this date, is a clinical diagnosis. So you would see short stature represented about 80%, cardiac defects up to 90%. Most common is the pulmonic valve stenosis, but there is also presence of hypertrophic cardiomyopathy, which is present, and with certain genes, we're going to discuss that. Chest deformities are present in about 70 to up to 95%. Cubitus valgus, typical facial features. And the interesting thing about this syndrome is the facial features, they change by age. They start off with a different facial features, and as they age, it changes. So in infancy, you would see hypertelorism, frontal bossing, high anterior hairline, and as they grow older in early childhood, it would develop into a triangular face, low set ears, curly hair, and as they become older, it changes even further. Also associated with coagulation abnormalities, peripheral lymphedema is also present. Undescended testes is another reason why endocrinologists see these patients, and that's present in about 70% of the children. Other features that are present in Noonan syndrome is poor feeding, failure to thrive. They also tend to have a low muscle tone, delayed milestones, and also there's a neurological profile of ADHD, autism spectrum disorder, and learning issues. Delayed puberty is also seen in Noonan syndrome, and also certain preponderance for certain tumors. So what are those various genetic mutations which affect and result in Noonan syndrome? So as the previous talk showed, that especially at the one thing is not completely known why short stature happens in Noonan syndrome, but it has to do something with the growth plates. So the pathway, the RAS-MAP kinase pathway, involves and stimulation of the pathway by a growth factor, which could be epidermal growth factor or fibroblast growth factor, which activates this pathway. And the pathway is then regulated further by the SHP2 protein, which is encoded by the PTPN11, which is the most common gene involved. And some of the other genes involved, SOS, RAS, RAF, MEC are further downstream signals transducers of this pathway. These mutations which result in Noonan syndrome are actually overactivating or stimulating mutations in this pathway, and these are listed here. So you can classify Noonan syndrome according to where the mutation is. They can be classified if they're involving the RAS proteins, or if they are involving the downstream proteins such as RAF, BRAF, and MEC1 and MEC2, or if they're involving the pathway regulators such as the PTPN11 and SOS1. So clinically, you can also classify Noonan syndrome according to the classical presentation of Noonan syndrome is mostly represented by these 4 gene mutations in PTPN11, SOS1, RAF1, and KRAS. So how does growth and stature play in this syndrome? So the mechanism of short stature in Noonan syndrome has been hypothesized to be as a result of growth hormone resistance, especially in the ones which have the PTPN11 mutations, because it was found that they have low IGF-I, low ALS, and a normal IGF-BP3, so that postulates the theory that there could be growth hormone resistance. But also this growth hormone deficiency reported, and this is based on stimulation test data. So some patients have growth hormone deficiency and some patients have growth hormone resistance. So it's not one universal reason of short stature. And also neurosecretory dysfunction has been reported in Noonan syndrome as well. And how do these children grow? So starting from birth, they do tend to have higher prematurity rates, and they tend to be smaller or shorter at the time of the birth, somewhere around a -1 standard deviation at the time of birth. They tend to have smaller head circumference, but their birth weight is normal. And this is even more significant in the ones which have the PTPN11 mutation. They are significantly shorter and thinner at the time of the birth as compared to some of the other mutations listed here. And the other mutation, RAF1, is also very similar to the PTPN11 when it comes to birth weight, length, and head circumference. After the first year of life, the height starts to typically drop off, and also it stays low during the prepubertal age group, and by the time puberty is starting to happen, height is typically below the 2.5 standard deviation. And puberty is late in Noonan syndrome. Reasons are not known why it happens, but it is late, and it starts after 11 in girls and after 12 in boys. And I'll show you the growth charts for Noonan syndrome. Boys do not have a plateau in their height curve, and they can grow until 20 years of age. So the first growth chart which was constructed for Noonan syndrome were done in the Netherlands by Witt, and the one on the left is for the boys. And these are the mean. These lines over here represent the Noonan syndrome mean heights over the age, and 1 standard deviation below and above the mean. And in the shaded areas for the general population. And as you can see, the boys, they keep on growing slowly. There is no plateau until about, this is 18, but they can grow to 20 years of age. For girls also, you can see a similar trend, but in the end, there is a plateau, and that could be because of the effects of the estrogen hormones on the growth plates. So these are the first charts which were constructed. Later on in 1988, Ranke also described the growth charts for Noonan syndrome, and these are scatter plots. This is for the males, it's for the females, and you can see the distribution of this is untreated Noonan syndrome. Distribution of height is a little bit more wide in the boys as compared to the girls, and it tends to be a little bit more tight as far as the height distribution is concerned. It was also described that bone age is typically behind in Noonan syndrome, and that differentiation in bone age happens after about 5 years of age, and there's on average bone age is behind by about 2 years, but that starts after 5 years of age. On the right side of the chart is growth velocity in children with Noonan syndrome. These are these dotted lines over here, and on transposed are the normal or the growth rate in general population. And you could see that in the early childhood, the growth starts to slow down, and it remains slow. And they do have a growth spurt. That growth spurt is much shorter as compared to the general population. And very similar graph for girls also. The growth spurt is also very small as compared to girls for the general population. But they grow a little bit longer than that. Final height, data on final height was also first shown by Ranke, and it showed that males can get to a height of 161 centimeter, and girls can get to a final height of 151 centimeter. These are untreated. So if you compare girls with Turner syndrome and Noonan syndrome, the height is about 6 centimeters better outcome untreated. Growth velocity in Noonan syndrome is slower than general population, and you can see that slowdown happens around 3 to 4 years of age, where the growth velocity starts to go down, and about 7 or 8, it starts to go down below what is considered normal of 5 centimeters a year, and it goes down below that. But the only difference is they grow longer till about even after 19 years of age. Some more data on the final height of untreated Noonan syndrome, and it varies according to the country from where the data was reported, and depends on the ethnicity. So for males, it could be anywhere from 157 centimeters to 167 centimeters as the final height. For females, 146 to 152. These are untreated children with Noonan syndrome. And final height, if you have there's a little note that if you have a mutation in the PTPN11, its final height is even lower than what is reported for all Noonan syndrome. Okay, so part of the slide is already covered, but this paper was a really good paper which showed natural, I would say, natural height in Noonan syndrome as differentiated by the genotype. So it's covered over here, but the circles which are fully shaded circles are the PTPN11 mutations, and they tend to follow the lower part of the graph over here. This is true for boys and girls. The open circles that you see are also PTPN11 mutations, but these are not, they don't have typical Noonan syndrome. They have Noonan syndrome with multiple lintagenes. So it's a different effect of the mutations. And even with the PTPN11 mutations, where the mutation and what syndrome they're causing, you can have different height outcome. I don't know if you are able to see these triangles out here. These are better height outcomes, and this is coming from the ones who have the SOS1 mutation. RAF1 follows similar path to the PTPN11 mutations. So the most common mutation, the PTPN11, which is around 50%, their phenotype is that about 70% they have short stature, and they tend to have a severe phenotype up to a -3.5 standard deviations below the mean. Their cardiac phenotype is more of a pulmonic valve stenosis rather than hypertrophic cardiomyopathy, and they tend to have some bleeding disorders as compared to the other Noonan syndrome. And also there's some risk for leukemias, which we'll look towards the end of the presentation. Starting from birth is very typical. The PTPN11 mutations are very typical of Noonan syndrome. They are significantly shorter, smaller to begin with, shorter at age 2 as compared to the other mutations. And by 3 years of age, they are, even significantly shorter below the 2nd percentile. And again, the mechanism for this is known to be growth hormone resistance. SOS1 is the second most common mutation in Noonan syndrome, and the height phenotype is actually better. Only 35% have, about 35% have short stature, and also the severity of the stature is less affected, somewhere around -2.2 standard deviation. They still have a similar cardiac phenotype as PTPN11 with the pulmonic valve stenosis. They do tend to have an increased risk for some tumor formation. So you have to be careful when you're treating them with growth hormone. Approximately the third most common mutation is the RAF1, which usually happens, this is the one which happens de novo without a family history. Stature seems to be severely affected in RAF1 as well. But this particular mutation does not have pulmonic valve stenosis. They tend to have a hypertrophic cardiomyopathy phenotype. Again, another thing to keep in mind when you're treating them with growth hormone. And there have been some cases reported in infancy which did not survive. RIT is another gene which is involved in roughly 10% of Noonan syndrome. It has the same cardiac profile of hypertrophic cardiomyopathy. However, the stature is less affected in this particular gene mutation. KRAS is another gene which is in which the cardiac profile is the same as the other two that we described, but again, the height is more affected. And also there is an typical feature of craniosynostosis associated with KRAS. So with every gene mutation, you'll get a little different phenotype, both for height, cardiac, and there will be another feature which will be different with the different gene mutations. This is an interesting one. I put it, it's not very common, but the fact that this was the first gene which was reported to cause Noonan syndrome, but this is was inherited in autosomal recessive manner, and also in infancy, and it was associated with sometimes fetal demise, and early infancy mortality was high with this particular gene mutations. Height seems to be affected about 60% of this gene mutation, and they do have increased risk for cardiac defects and also certain leukemias. And also with the same gene mutation, autosomal dominant pattern has also been reported, as well as autosomal recessive. So it makes it even more interesting. Okay, in this slide, I put in there are Noonan-like syndromes, especially this one with the loose anagen here, and this is caused by SHOC2 gene mutation, and the height phenotype is more severe with this mutation, and they have actually growth hormone deficiency, which is opposite of growth hormone resistance in the PTPN11 mutations. Gene mutations caused by A2ML1 is also interesting. They also cause a Noonan-like syndrome. Included here, I want to show you that if you have a mutation in A2M1, and there are family members who do not have any features of Noonan syndrome, and they carry the same mutations, but there would be a family member who would have features of Noonan syndrome. And here is a 3 generation with the same exact mutation, and you could see that not everybody would have the same exact phenotype. The height also is very variable in this genetic mutation. It could be very severe, and I've seen a patient who has a positive 2 standard deviation in height. They're very tall also. So could never really predict the exact height phenotype from a gene mutation. Okay, what if you look at just the most common versus the one without the PTPN11, and try to see if is there any difference in their height phenotype, and you know, how do we figure it out? And you know, when we talk to patients, you know, if you have a particular gene mutation, how do we counsel them about the future height? So if you just look at RASopathies, all the RASopathies put together, the PTPN11 would actually be somewhere around average height, because there are certain other gene mutations which give you even worse height phenotype, such as HRAS. But the mutation of HRAS also cause Costello syndrome, which has even severe height phenotype as compared to PTP. So if you compare PTPN11 mutations, it comes in the middle of the height phenotype. And the SOS1 is definitely a more favorable height phenotype. And if you just look at Noonan syndrome, again, PTPN11 comes in the middle, and actually it makes sense because the classical Noonan syndrome is described in the ones which had the PTPN11 mutation. So if you're comparing amongst them, then the height phenotype for the PTPN11 comes in the middle. But the ones which do better for their height outcome are the ones with the SOS1 and the BRAF, and the severely affected is the RAF1 and the SHOC. So when you know the genetics of these patients right from the beginning, you can start to counsel them how it will look like their journey as far as height is concerned. This slide over here shows a collection of all the observational studies which have been published for Noonan syndrome, and we look at the frequency of short stature if you have the PTPN11 mutations or not. And actually, if you look at the percentages of short stature is very similar to one if you have the mutation or not. And if you look at the severity of short stature, it's also comparable if you have the mutation or not. Some studies say it's a negative 2.6. Some studies have reported much more severe height phenotype. And there was only, I think in only one study, it shows that the height phenotype was significantly different as compared. Sorry, I think the reference for some reason is not showing up. But this study was by Lemel et al., which showed that the height in PTPN11 mutation was significantly shorter, more severely affected than the ones without. Okay, another study showing the natural history of height in Noonan syndrome, and this is divided according to the genotype. These are untreated patients. So the most common mutation, PTPN11, they start off by having a height of -2 standard deviation. And as they grow older from 2, 5, 10 into adulthood, their height standard deviations, they stay about the same. And if you have a SOS1 mutation, the height phenotype we were talking about is not that severely affected. And there is a slowdown from age 2 to 5, but then after that, they do catch up again. And then the height deficit is not as severe, and they end up pretty much where they started in terms of standard deviations. So not only the mutation, but also how they grow through the early childhood also affects the standard deviation. So somewhere over here, you would be more concerned about their height, but when they go into the preteen age, their height actually tends to be getting better again. Similar sort of story with the RAF1 mutations. Will have a much severe phenotype to start off with, but naturally their height does improve as they get older, and they end up with the -2 standard deviation in adulthood. These are untreated. KRAS is goes opposite. They start off with a better height phenotype, but as they get older, it goes towards the -2.4 or -2 standard deviations. So not only the genotype, but the age group, puberty, timing of puberty plays a role in changing of these height standard deviations. Okay, a little bit on IGF-I levels. Generally, IGF-I levels have been shown to be low in Noonan syndrome, and they're lower in the ones who have the PTPN11 mutations versus the one without. Also, after growth hormone treatment, the IGF-I levels, they do go up, but not so much in the PTPN11 mutation as compared to the ones without it. But definitely, as with some other growth, many other growth conditions, rise of IGF-I is correlated with the growth velocity. That is also true for Noonan syndrome, like other growth conditions. Okay, so now we know a little bit about just the natural growth history of Noonan syndrome. Now we can look at when we start to treat them with growth hormone therapy, how is that experience and how does that change? And we can learn something about it. So the data from the growth hormone treated Noonan syndrome was initially published as observational studies, and they were in early 2000s. Children, there were a small number of children which were reported initially. The mean age of start of growth hormone therapy was somewhere from about 6 to 11 years of age, which is actually late as compared to some of the other growth conditions. So they get picked up late and get started late on therapy. Mean height standard deviation was somewhere around -2.8, and they were treated for 6 to 9 years on average. And you could see a change in their height of about 1.3 standard deviation to 1.7. So yeah, the height improves, but it takes about 6 to 9 years to see an improvement of about 1.3 to 1.7 standard deviations. So it takes a long time to see a significant change in their height. Okay, some of the bigger studies, which are based on national registries, showed these are children. They have like up to some of the studies have up to 600 children reported, 400. So this would give us a little bit better insight into the height and response to growth hormone therapy. Again, it seemed like that the age of start of growth hormone therapy was much later in Noonan syndrome, and it was 9 years to about 11 years in some of the studies. So that theme still continues. The height standard deviation in this larger studies have been shown to be affected. It's a severe height, which was till about -3.5. And these studies collected data for about 3 years to 6 years. And you would see the height standard deviation scores have changed from a 0.8 to a 1.2 over these many years. So on average, it's roughly about, you could say, a 0.2 standard deviation per year change in their height. So as compared to growth hormone deficiency, this is a relatively slower change in height. How is their growth velocity once they're treated with growth hormone? The first year growth velocity is the most important growth velocity, as we know. And before starting treatment, the growth velocity is roughly around 4.4 to 4.9 centimeters a year. First year can go up to between 7 to 8.5 centimeters a year. This rate of change is actually slower than the ones that we treat with growth hormone deficiency. And what is interesting is the growth velocity after first year is not really sustained in the second and third year, and there is a significant slowdown in the growth in the second and third year. Okay, this is data which is taken from ASTER registry, in which it was a 4-year experience of growth hormone therapy was published. Mean age was around 9 years. Baseline height was -2.6 on the regular growth charts. And after 4 years, there was the height was around -1.3 standard deviations. And the dose of the growth hormone has been shown over here, increased at 4 years were higher dosing of growth hormone. And not very clear over here, but you can see gradual improvement in height standard deviation. There is slow catch up going on. And the increment in height is also shown over here for boys and girls. And you could see, I'll show in some of the other slides, the year 3 and year 4, there is not much increase in the height. The first 2 years have seemed to be make the most difference in their height, but the 3 and 4 years doesn't seem to change much. Okay. Nordinet study also reported about 30 children, and 17 of them were prepubertal. Average age was around 8.3 years. Their baseline height was -2.6 on the general population growth charts. On the Noonan syndrome was -4. And after 4 years of treatment, the height improved to a -1.4 standard deviation. And on the Ranke charts, it improved to +1 standard deviation. On the right side is the representation of the same data. And you could see the height did improve and the ones which were treated, but you could see the plateau of the improvement in height in age 2. So the first 2 years, you see a good response in height, but the year 3 and 4, there is a slowdown in the improvement in height. Okay, and this is data taken from the same study, which showed that the percentage, the frequency of children who were short when the study was started was about 80% below the 2 standard deviation, but by age 4, only 20% were left to be below the 2 standard deviations. So there was an improvement overall in the frequency of short stature as well. This is data which is taken from the KICS, which is the 25-year experience of growth hormone treatment. It was published by Ranke. And this graph over here shows charts for girls with Noonan's, and you could see the pre-treatment height, how they were distributed. And after the treatment, you see that there is a significant improvement in their height. There were some who were not good responders, but most of them responded well. And the shaded area is the Noonan syndrome charts, and the dotted lines are the general population. So some were even able to make it into the height curve for the general population. Before treatment, there was only 1 or 2 cases. So overall, with the long-term treatment, you could see an improvement in the height outcomes. For boys, also a similar curve appears, that after treatment, before treatment, you could see their height below the mean and also below the third percentile for the general population. After treatment, you could see much better response. But again, for males, the response to therapy was also much more widely distributed than the girls, which you saw. So even before treatment, the boys, the height seems to be also more widely distributed, and also after treatment, the response is more much more different in boys. So it seems like the genotype is also affecting the age, the different age group in terms of how they're growing affects their height. Timing of puberty affects their height. The gender also affects height. So it seems like it's multiple reasons for height outcomes in Noonan syndrome. This study also was the first one to show a first-year height velocity correlation, and it showed that negative correlation was with the age of start of therapy. We know that for other height conditions, and in Noonan's, the age of therapy start is late. Positive association was also seen with, just like other growth conditions, the height at the start, the dose of the growth hormone used, and the number of injections given per week. But the interesting thing in Noonan syndrome is birth weight, which was positively correlated with height. So if the birth weight is better, you will have a better height count. So now we have about at least a 5th or 6th factor which can affect their height count, which is birth weight. Okay. And we looked at the height outcome with all the mutations put together, or even unknown cases. But this chart over here looks at just the presence of the PTPN11 and without the PTPN11. And the ones which are in the red are the ones which are without the PTPN11 mutations. And these are again from some of the observational studies. And you could see the height phenotype, even if it was worse to start off with, but the response to therapy was better, and the ones which did not have the PTPN11 mutations versus the ones which had the mutations. It was showed in at least 3 of these studies that the height outcome is better if you do not have the PTPN11 mutations. But then again, these studies are only 1 to 3 years studies. So if you look at the data from the longer term studies, which was published recently, it actually shows, this is actually a baseline data of a longer term study in which patients with PTPN11 were compared with without the mutation, and their age, gender, growth hormone dose, height, standard deviation in the beginning of the treatment were very similar. The only difference, but not statistically, was the IGF-I levels were low and the PTPN11 mutations. So otherwise, the characteristics were very similar in the ones with and without the mutations. And how did they respond to 4 years of growth hormone? The response was about the same. So the one with the PTPN11, they were slightly lower at a negative 3.1, but they ended up at negative 1.9, and the ones without the mutation ended up negative 1.7. So there was no, and these are the general population charts. This is the Noonan syndrome specific charts. So it does, the long-term data does not really show a difference between the response if you have a mutation or not. This is our own data from CHOC, a 5-year experience of growth hormone therapy. Then again, this is just data that we collect from the clinic. And you could see this is all mutations put together. There are about 25 children, 13 with PTPN11, and others have different mutations, and 8 of them are unknown mutations at the time. You can see their height standard deviation score was at negative 2.4. Over 5 years, it did improve to a negative 1.6, but it took 5 years to get there. And IGF-1 levels, they also went up, but not immediately after treatment. And they tend to be higher at about 3 or 4 years. And I think that is not probably because of growth hormone therapy. That's probably because of effects of puberty, improving their IGF-1s and BP3. And height velocity also improved from baseline of 5.5 to a 7.2. But then you see again in second, third, fourth, and fifth year of therapy, the growth velocity goes down to pre-treatment growth velocity. So it seems like the best benefit is in the first 1 or 2 years of treatment. This is the same data represented differently, and different color bars are different mutations, which is the PTPN11 is the one in the blue, orange is without the mutation, the other ones are without any known mutations. And you can see that there is an improvement in height, but there was also no difference in their genotype. It didn't really matter what mutation, what gene mutation they had, how their height is going to respond. Then we started to look at, how come this is happening? A disorder which is highly dependent on genetics. How come we don't have a clear-cut answer, like a gene or a gene mutation? How come that cannot differentiate the height outcome? So we started looking at, maybe we should look at the most common mutation in the PTPN11 is at the 308 residue. This is the the PTP domain of the PTPN11 gene, and these are the other 2 different domains. We'll talk about the leukemia-associated mutants, because there are some mutations which can also increase risk of leukemia. But just for now, we started looking at this residue, the 308, and we started to differentiate the data, and just compared only the PTPN11 mutations, positive mutations, and the ones which had the mutation at the 308 versus the one without it. And if you look at, then the data starts to make a little bit more sense. If you have this particular mutation, you have a little bit better height phenotype to start off with the negative 2.5 standard deviation, as compared to the ones if you don't have this particular mutation. And their growth velocity at baseline is better. So they're already doing better. The height is a little bit better to begin with. And they do respond in their terms of their IGF-1 after growth hormone therapy better than the ones without this mutation. So there was a significant difference in their IGF-1 production as well. Their height velocity was better, but not significantly better. But it seems like the first year is a better response. And in the ones which do not have this mutation, they have the other mutations. They are more severely affected. Their baseline growth is slower, and they also don't respond to growth hormone therapy as well. So even within the PTPN11, you can start to see the difference. I tried to look up if somebody has published on it, but I did not find any publication on this particular gene mutation. And this is submitted to the PES for this year, pending decision for poster presentation. But overall, if you look at the PTPN11 versus not, the short-term studies show that there was some difference in the way they responded, but the long-term studies do not show. Or it's possible that maybe in the beginning there is a difference, but later on the ones with the PTPN11, they slowly catch up, and in about 4 years of therapy, there is no significant difference which is left. Okay, so just the last few minutes, we talked about growth hormone therapy, but what about to look at some of the adverse effects of growth hormone therapy? So as far as the syndrome is concerned, in particular, you have to be careful about 2 different entities. One is the cardiac phenotype and how that gets affected with growth hormone therapy. And most importantly, not so much about the phenotype with the pulmonic valve stenosis, but if they have cardiac hypertrophic cardiac myopathy, because that can get worse with growth hormone. So does it get worse or not? These are the ones, the mutation that we looked at. The RAF and the RIT mutations are the ones which have increased predisposition to hypertrophic cardiomyopathy. And it was shown that there was some increase in the hypertrophy in about 3 out of the 65. And in one of the 14, there was a increase in the hypertrophy after growth hormone treatment was started, and this was a patient with the RAF1 mutation. But larger studies like the NCGS KIGS, they have shown no side effects as far as cardiomyopathy, and it has been deemed safe to use growth hormone in terms of cardiomyopathy. But what is recommended is to do echocardiogram after starting growth hormone therapy every 6 months to 12 months initially, and after they are a little older, to do it at 5-year and even at 10 years of age. So initially you'll have to do 6 months, 12 months echocardiograms, but when they get older, the chances of worsening of cardiomyopathy is less. And these are the references over here if you want to look at the exact case reports of measurement of ventricle wall thickness, which was shown that there was no increase in the left ventricle wall thickness with growth hormone therapy. And there was only one case of hypertrophic cardiomyopathy, which was found to be worse after growth hormone therapy. So as far as leukemia risks are concerned, so in general, somatic mutations in the RAS-MAP kinase pathway are responsible for majority of the tumors. That's a known fact, but germline mutations behave differently than somatic mutations. But even with germline mutations, you do have an increased risk for leukemogenesis. So certain PTPN11 mutations are reported to cause some myeloproliferative disorders. CBL is another gene. It's very rare, but it has been associated to cause JMML. And also RS is also linked with leukemogenesis as well. So going into PTPN11, there was a interesting paper which was published in the Netherlands, which looked at cumulative risk of malignancy if you have a PTPN11 mutation. And it was found, according to statistical analysis, that it carries a 3.5 times higher risk for malignancy. And that is about 23% by the age you get to 55 years of age. And there have been some case reports of post-growth hormone treatment in PTPN11 of a brain tumors. 2 cases of 2 different brain tumors have been described. And also there is this specific mutation in the PTPN11 causes increased risk for JML. KRAS is known for JMML, and RIT1 mutation also 1 case have been reported to cause ALL as well. SOS gene mutations give you more like a solid tumor increased risk. And I've just listed, I'm not going to go over these exact risk with these genes. There are, if you want to look up, there are guidelines what to do if you have this KRAS mutations or PTPN specific. They need to get their CBCs done almost every 3 to 6 months. It is a good idea to refer them to a hematologist, oncologist, depending on what exact mutation. And I personally hold off on growth hormone therapy till they're about 5 years of age. So to conclude the presentation, it seems like the baseline height overall is a little bit lower for the ones which have the PTPN11 mutations than the ones without. And only in 1 study, there was a significant difference. The gain in height after getting growth hormone therapy also seems to be overall roughly around 1.2 standard deviations over the 5 to 6 years of treatment. The ones with the longer studies have shown no significant difference according to the genotype, but the shorter studies have shown that the ones with the mutation grow slowly. Then our data has shown if you have this particular mutation on the 308, you have less severe of height phenotype even amongst the one with the PTPN11. Naturally, the height is the least affected with the SOS1 mutation. As far as the first-year growth is concerned, it's lower in the one with the PTPN11 mutation, but then with other factors like height at the time, growth hormone dose, number of growth hormone injections, and birth weight is also an important factor to look at when you're looking at the first-year response to growth hormone therapy. As far as the final height is concerned, actually birth weight is important to reach the final height. There was a positive correlation. then how they were at the baseline, that positively correlated. The change in the first year of height standard deviations affected, and males tend to do a little bit better to reach their near adult height. Cancer surveillance is recommended for these three mutation genes, in particular mutation in the PTPN11. Overall cancer risk is low, and right now there is no specific contraindication to use growth hormone therapy. And I think with that, I will conclude my talk.
Thank you, Dr. Mangu. Very comprehensive talk on Noonan syndrome. Brings up some very important questions for the clinicians in the room and others. If you have any questions, raise your hand. Let's see if there's any questions on the Zoom. Yeah.
How is that? Is it over general population? Some of the numbers are pretty low, like especially some of the brain tumors. So did you think that it was specific to their genetic mutation when you compared it to the general population? Is having a higher risk of those particular tumors?
Yeah, so KRAS and CBL, they have more, in general, all KRAS mutation and CBL. But specific mutation of the PTPN11, the one that I listed, has been linked. But there was one study done with, it was a statistical analysis in which they said there was a 3.5 times more risk for cancer. And I think there's another, I didn't cite one, but there is a cancer registry German data also available in which they looked at all retinopathies. And there was also increased risk in that. If you want, I can give you that paper. But there seems to be a little higher risk in general.
So as a general endocrinologist, you said it's a clinical diagnosis to start with. So if you diagnose someone with Noonan syndrome, the genetics back with all of these risks of cardiac and sort of risks, do you recommend kind of holding off until all the genetic testing is back and be very judicious in how you use growth hormone in the Noonan's population compared to what we knew in the past? Because I think a lot of the registries and things were just before we knew about all these risks.
Yeah, so I personally wait for genetics to come back. And if they have, if the genetics is negative, which can be in about 20%, you want to make sure there is no hypertrophic cardiomyopathy because
Echo.
echo. So pulmonic valve stenosis does not seem to be, an issue with growth hormone therapy. If they have a phenotype of hypertrophic cardiomyopathy, I think they need to be followed. Again, there's no contraindication.
Yeah.
So
eventually all can get it, and it's a long-term follow-up. But there's a specific gene within PTPN1 higher risk for JMML, and they can even get growth hormone.
I think till 5 years of age, the recommendation to do surveillance until 5 years of age.
Out of that pediatric space. So I have some of them that never had testing done and they've been treated with growth hormone, now they're finishing up. So with this data that we have, is it beneficial or is there recommendations to go ahead and have the genetic testing done for future cancer risk and surveillance?
I don't know if it's a recommendation, but I would personally do it. And I've done, few and they've come out positive with the new panel being available. So the InVite has that skeletal dysplasia, but not all the Noonan's genes are on the skeletal dysplasia. There's a separate panel for Noonan syndrome. So I've been using InVite because we're using InVite for the other stuff.
InVite?
InVite, yeah. And Embry Genetics is also, they have a Embry.
Embry Genetics?
Yeah,